People, if it
Okay.
started.
Thank you, Fiona. Thank you.
Okay, I will just continue then if that's okay. But please interrupt me if there's anything. I can all see the chat as well, so if there's any questions, please you just interrupt me and that's fine. So after talking about the how it is like for people with chronic pain, young people with chronic pain to experience pain, I'm going to be telling you about a new model for managing pain that we developed and how we involved young people in this process, in the research process, and how this model is now being used and the plans we have to evaluate it. So we're going to go full circle into generating the evidence and bringing the evidence into practice and going back with the research perspective to evaluate how the evidence is being used. So that's today. So I'm sure you're aware of the definitions, but I just wanted to include here anyway. So the focus is persistent pain or chronic pain. So it's just pain that lasts persists past the normal healing time. And it can be recurrent or ongoing, and it normally lasts beyond 3 to 6 months. And we all know the numbers, but again, just for the rationale for the impact of why we do this, there's a whole, the figures are there, and chronic pain is the leading cause of morbidity in children across the globe. It really affects their quality of life. There's a huge financial burden in the healthcare systems and on the families, on the parents. They're having to pay out of pocket expenses every year or having to miss work. So we're going to go into detail on how the figures actually have an implication, and that's an implication on their lives, and that's the focus of today. So back in 2020, we're looking into the interventions that are out there for children with chronic pain, and most of those interventions were quantitative studies, or they're based on quantitative evidence. And we really wanted to understand, okay, but what is it like for, the young people who are experiencing the pain? And to do that, we need qualitative evidence. We need to understand the experiences, their perceptions, their preferences. Without that, we won't be able to build a good intervention, a good management program. So we went to the qualitative evidence, and we brought all of this evidence together. And this work is now available at the Cochrane Library. If you scan the QR code, it should work. I tested it. But it's basically a meta-ethnography, which is a type of qualitative evidence synthesis that we done looking into how children and young people experience chronic pain. And the specific questions we asked, so there are multiple questions we are asking. So the main one, it was to really understand how children and young people who have chronic pain and their families think about pain in general, how they think about it. How is it for them to live with a chronic pain condition or chronic pain? How they think about how the healthcare and social services treated their pain, and what they want from the services. So those questions are practical questions that would help us. And the main goal was really to create recommendations that could be used by the same services that are providing the care. I'm not going to go into a lot of detail on the methods or methodologies we used, but please, if you're interested in that aspect of research, get in touch with me. More than happy to talk about that. Here's just an overview of the papers we included, the participants. So we are really interested in the whole family, as you can see here. We not only included the children, but also the parents and the siblings. And I just wanted to highlight here the impact on the siblings is really poorly researched. There's a huge impact on the siblings. That was one of the gaps we found. We're looking to high-income countries because this work was to inform how we can make recommendations within the UK context. So we look at countries that had similar context to the UK, and we're not really specifying or looking for a specific type of chronic condition or chronic pain. We just wanted to look across the board, and that kind of resulted in the inclusion of 15 plus types of chronic pain in different conditions. So it was interesting to see how they had nuances on how children experienced their pain. Okay, so the interesting aspect of it. So let's talk about what is actually interesting, what we found. I think we can really split our findings in three main findings. And the first one is what we call the journey of living chronic pain. So the journey was a term that the young people that worked with us in this research really wanted us to use, because that's what they used on their daily lives. That's how they described their lives with chronic pain. And what we found is the chronic pain is a mark. So once the pain starts in that family, or that child develops the chronic pain condition, they really can see a clear mark between the life before and after the chronic pain. The family routine, it changes to organize around the pain. So for example, everything is planned to avoid the chronic pain exacerbation, planned to avoid a pain flare, planned to fit in the pain management that it sometimes needs to be done at home. So it really changes the family life and dynamics. We see normally what we found is the mothers were the main people there. They were really reinforcing the pain management strategies, or caring for that child, and really making the decision of helping the child to manage. So that affected the relationship with the partner if the mother was married. So the relationship with the husband or partner would change. There's a whole change on the sense of normality for that child or the young person, especially if they are getting towards being teenagers, the teenage years, where they start to compare themselves with their peers. So they start to feel different. And that has a huge impact on their social lives, on how they see themselves. The chronic pain condition they have, or the chronic pain, might become part of their whole identity, or part of their identity. And that's quite important, because they are just building their sense of self at that stage, and being able to join in things, being able to be with their friends is so important. But we found that most of them would have to miss school because of the pain most of the time. So there's also a huge journey towards a diagnosis. Families see that as a main aspect. So something's wrong. If I get a diagnosis, I might be able to fix it. So that's the starting point for the families. So that leads them to navigate through services. And I will talk through it. We developed a model to explain this. I'll talk through it in more detail. But what we found is services are often fragmented. As we know, services, they're built based on conditions or disciplines, and chronic pain most often sometimes slips through the cracks if you're treating a specific condition. Sometimes you're just treating the condition, and chronic pain is a symptom. So that happens quite a lot, and the uncertainty of what comes next in terms of the healthcare services that they're navigating. So a lot of uncertainty. And as you can see here, I think the main picture I'm trying to create here for you is that pain impacts their whole family, their whole lives. So another thing we found is that when families first receive start with the pain, the starting point is the idea is that the pain is caused by a physical cause. So it's most of the families who have the biomedical conceptualization of pain, that's how we say it, is that the pain is physical. There's got to be a way to fix it. If only I have a diagnosis. So most often families will go to services with that kind of mindset. That's all they know. And what happens is that if they have suggestions for other things, such as psychosocial approaches or psychosocial causes, this can be really difficult for families to understand. What we found is that if this wasn't really communicated with families about why I'm telling you the psychosocial treatment can be helpful, families could, parents, for example, could feel blamed as if they're the cause for the child's pain, or children sometimes and young people felt that they're being told the pain's all in their heads. We know that's not the case, but it's just because of how they think about pain at the very early beginning that causes them to really reject anything else in terms of psychosocial approaches and causes. So that's a very important finding, because it really changes the way we practice and do things in a way that why I'm telling you about the psychosocial approach or treatment, and really understanding that's quite stigmatized for this group. Another key thing was parents, as I mentioned briefly before. They're extremely essential in managing the chronic pain in the child. So they usually carry out the management at home most of the time. And what we found is that they actually were the ones responsible for helping the child to adhere or not to a management routine. And that could be anything, could be physiotherapy, exercises, it could be even biological injections. So it really depends on the condition here. But what we found is that if the management strategy was too disruptive of the family routine, parents were less likely to help the child adhere to the management strategy or to help the child do the management strategy. So, for example, things that are too painful, having to do the injections or having to do the exercises, those things were less likely for parents to do them if they didn't completely understand why they were doing those things. So another very important thing we found is that parents, they want to share responsibility with the healthcare professionals. They are having to do all of those really difficult decisions. They're having to make all those difficult decisions, such as, do my child really need this surgery, or do my child really need this injection? So having the shared responsibility with the healthcare professional really helps. That's what they're looking for. At least that's what the evidence told us in our patient and public involvement group as well. Okay, so that's a lot, just in terms of the main findings we had. We developed this model to help us navigate and understand what is going on here for families. So this model is basically bring all those findings together and to understand, to help us understand what it's like for families from the moment they have pain, or when they have pain that is not managed, until they go to the services, and how that happens and what happens to them. So I'll talk you through it. So if you start at the initial box here, so if the pain is severe, moderate, or poorly managed, they are having difficulty managing the pain. As I mentioned before, this affects their whole family life, affects their relationships. They will have the biomedical conceptualization of pain, the way they think about pain when they first access services. So that means what they're looking for is a cure, something to get rid of the pain. The pain is physical, give me something, I want to get rid of this pain. So that's normally what we found that happens when they first go to services. And obviously this is ideal, but not always possible, as we know, for many conditions. So what happens is the family's expectations are not met. So in this path A here, I don't know if you can see my arrow hovering around. So what happens then? They decide they're going to try to manage on their own. There's got to be something I can do. And what happens is they can get stuck in this cycle for many, many years. We've found families that were stuck in this cycle for 7 years or more, just really trying to find a cure. And that can be exhausting. We found the families lose hope, they lose trust on the healthcare sector, and it can be very difficult. And we found 2 different ways the families can get out of this path A and move on to path B, which will be adapting to live well with pain. So the first one is, at some point, if they're stuck in the cycle, they might realize, oh, let's try something else, because just pursuing those treatments it's not really helpful. So they might try to go to therapy or do some psychosocial treatment approach, and this might help them. So they start to shift the focus slowly. That's one way, but can take a long time for them to get here. Another way, which we found is much faster and helpful for families, is if they have the expectations managed at the beginning, right at the beginning. If the pain cannot be cured, if the condition cannot be cured, having a trusted professional telling them that and helping them understand that there are ways they can adapt to living well despite of the chronic pain, that can be really helpful in changing their mindsets or the way they view and think about pain. And that they can then start to manage and live well with the pain. So it's just showing the key importance of the healthcare professional in this journey the families go through. Okay, so another thing we've done with those findings, we wanted to go beyond just understanding what it's like for them. We really wanted to see what would help them, what can be done. And one of the findings, one of the things we developed with the young people and the families based on the evidence was this model. This is a family-centered theory of what a good chronic pain management strategy would look like. And I know there's a lot of information, so I'm not asking you to read it all. I just want to point you to certain things on this model. I think the first thing I wanted to highlight here, as you can see, there's 3 different background colors. So you have the family in green, the healthcare services in yellow, and here the community and schools in purple. And the idea is that one person or one service cannot deal with the pain on their own. They need a whole systems-wide structure to help them, because the pain, it is a complex issue, it's a biopsychosocial issue that will need multiple avenues to be treated or to be managed. So here is just showing how all of those things can be linked up. So the healthcare services talking with the schools and the community, going back to the family. So the family here, we put there as a core aspect because they are managing the pain. Families are managing the pain from home most of the time. And another thing I wanted to highlight is that this whole model was developed based on what families wanted, so their desired outcomes. And the things that came out from our review and from the group we're working with was they wanted a cure. That was the thing they wanted. So we had to add this there, which makes sense. That's what they want. But knowing that this is ideal, but not always possible, what is the next best thing? Pain relief. Living well with pain, and then pain prevention. So those were the outcomes. And then we just from there just started to design based on the evidence, what are the things? And we pointed multiple gaps as well. So there's plenty of room for improvements there. Okay, so just to bring it all together, what does this mean for you guys that might be working on the clinic or working day to day? So we had a whole section on recommendations for practice that you can access.
Hello. Hi, honey. You all right?
Sorry.
Is the top ready for click and collection?
I don't know if this.
Can we mute the mics, please? Please, can we mute the mics? Thank you.
So just continuing then. Sorry about that. So the first thing is the service or of the management of chronic pain needs to be biopsychosocial, needs to be integrated with support in the community, and needs to be tailored for children. Applying models that they're already out there for adults won't work for children and young people. We also found that it's very important to have a multidisciplinary team for those who have more complex conditions. There was quite a gap in terms of pain assessment and management for healthcare professionals and for parents. I should have added that, and families. So things they could be doing at home. And it's so important to develop and test an approach to ensure the right care is done at the right moment for the right service. So, and having clear clinical care pathways to get rid of the uncertainty families have when they're navigating services, and even the healthcare professionals. Who do I refer this to? What could be done next? Who do I have to work with? So the next thing I want to show you, fingers crossed this will work, is a cartoon. This cartoon was developed with the group of young people and families that worked with us, and it's showing what are our main findings. It's basically what the young people wanted other young people with chronic pain to know if they are just at the start of their chronic pain journey. So I hope you enjoy this, and fingers crossed it works.
When you have chronic pain, life can feel like a roller coaster.
Sorry, just pausing up. Can you hear that?
Yes, we can. Thank you, May.
Oh, amazing. I'll just go back then. Sorry.
When you have chronic pain, life can feel like a roller coaster. It's like everything turns upside down. Buckle in, everyone. Some days, pain just seems to come from nowhere. It can make doing things at the last minute pretty tricky. And it stops my plans in their tracks. My pain can become the centre of attention and take over our family life a bit, which my brother and sister can find annoying. But in many ways, it's brought us all closer together. Pain can cause me to miss school, so it can be harder to keep in touch with friends. Hello, remember me? That's why my parents do everything they can to get me there, even when I don't feel like it. It's tough sometimes, but I know it's because they love me, and they have a lot on their plate. Seeing my friends and family usually cheers me up, but sometimes I just don't feel like myself. And other times, I just want to be seen like everyone else. That's why I meet up with young people who are also in pain. Support groups aren't for everyone, and it took a while to find the right one. But I like hanging out with people I feel normal with, who get me and don't judge. If people don't have chronic pain, they don't always understand. My family are great at fighting my corner. It was a bit of a battle to get the right stuff in place at school, so I could still be included in everything. Even some doctors and nurses needed schooling on my condition and managing my pain. The thing is with pain, it's unique to you. And sure, I want an instant cure and no more pain, like everyone else. But it's not always possible. And what we've realised is that talking is super important. When doctors and nurses understand how I'm feeling, I can get the best treatment to manage my pain better. So when looking for help feels like a drag, or even a bit scary, I try to remember, if we work together, we can make things better. There are still some bumps in the road, but I'm learning to ride them out, with a little help from these guys.
Okay, I think I saw a hand coming up. So is there any questions from the people would like to ask?
Hi, May. I put in the chat that it was really good and got the messages clearly across. And I just wondered if people can access that freely, staff and for use by children, young people and families.
Yes, sure. I can definitely share the link in the chat later so you can have access. It's freely available, and the research is also available, and I can share a link for that as well. Thank you for the really nice comments. Appreciate. If there's anything else, please feel free to interrupt me because I cannot really see the chat. Okay, so this next section, I'll go through it quite quickly because it's potentially is quite research oriented, but I wanted to share how we involved people in what we did. So I'm sure that if we haven't involved young people and their families in this research, it would look completely different because so much came from them as well and the evidence. So we had 12 children, young people, and they varied in ages a lot. So the youngest one was 8 and the oldest one 20 years old. They were involved in the research I just showed you. It was completely co-produced with them. It's completely co-produced with them. So these are the stages that we go through when you're doing this type of research that I just presented. I'm not going to explain each one of those phases, but it's just to show you how each one of the stage we carefully plan how we're going to involve young people and their families. We also had an advisory group with healthcare professionals, policymakers that worked with us as well, just to make sure their findings would be translatable to practice. And we provided training. So we first assessed what kind of training needs they had. this was right at the beginning of COVID, so many people, they were not using Zoom, not all of that. So we talked to them, we explained how to use Zoom, what is research, all those very fundamental things when you are getting involved in a research project. And we had multiple workshops. We had planned 2, but we ended up with 4 because there was so much to be done and the young people were really keen and involved. So it was just great to continue to work with them. So our workshops, they followed this kind of structured. So we always provided an additional meeting before the workshops to talk through what we're going to do on the day. And we created ground rules at the beginning, which was done with the young people. We had icebreakers and all of that. And because we're talking about sensitive things that can be quite difficult to recount, we always provided support at the end with support organizations that are quite neutral and they could get in touch. And I think the star really of this whole thing is that they were able to really get involved in the findings. So they look at the evidence and they were able to give their own perspectives and what does that mean for them who are going through the services and living with this condition. And the way we did this, as you know, I mentioned, our youngest person was 8 years old. So we created those cartoons. All of our findings were kind of translated into cartoon format, so we could bring it to them and have a discussion about it without being too boring or too wordy. So we tried to make it quite engaging. So here's just an example of one of the cartoons we've done. We tried to keep it quite open-ended, so they could just share their views without really feeling like they had to say a certain thing. So just moving on, another thing we done was using infographics to keep them updated about what was going on in the project. This was very important. So they felt they were part of it, and it was, again, was quite interactive and visual. And the last thing, which was very important for us, is that they were with us disseminating all of this. So we co-presented at academic conferences. We co-presented at the nursing conference in Cardiff. One of them was our lead for a social media account. So a lot of it came, the dissemination was done with them, which was really good. So the last thing, I'm aware that I'm probably running out of time. So the last thing I wanted to share with you today is that we're extremely excited that this model was picked up by a service, the service in Cardiff, and they're using the model we developed with the young people for the service they're implementing, which is amazing. And what we're going to do now is to evaluate and understand if the way they're using the service is working or not, how they're using the service. So what I wanted to, in the last few minutes we have, just talk through what our plans are for evaluating the service. So this is a very new service. I don't know if you've heard about it, but it is a service in Cardiff, in Wales, that is an integrated model of service, integrated model of care that is going to be linking in with the different university health boards hospital health boards across Wales. And it's very early days for the service. It started last year. They have 150 children, young people they're looking after now under their care. And the ambition for the service is to expand into a community-based format, so reaching out to schools, which is what we really wanted to see based on our model. So we've been working with the lead for the implementation, Dr. Nicholas Wilkinson. He's been the main person implementing this, and he's on board with our evaluation. And the idea is to really understand and guide the way the service is being implemented, because the idea is to roll out across national level in Wales, this service, and we want to make sure it works. So we are really asking, what helps the new children's chronic pain service work? For whom is it working? In what kind of settings and how? So you can see we're not only asking, does it work or not? We want to break it down and really understand how is it working. So again, I'm not going to get into details about the methods, but we are using a realist evaluation, which is quite common in this type of research, looking into complex interventions and services. And the idea is to really look at different sources of data to create a bigger picture. And it's a very collaborative approach, so it involves patients, the public, key stakeholders, people from the service, people from schools, across the whole stages, so it will be co-produced. So the young people already helped design this evaluation protocol that I'm presenting to you today, and they will continue to work with us, with their families. I also want to involve third sector organizations and other relevant stakeholders. And the idea is to bring the systems-wide perspective that I told you about right at the beginning. So I'm going to be collecting data for all of those different domains. So I want to understand, how is the service working for children and their families? How is the service working for the healthcare professionals, so they have everything they need to be able to provide the service? In terms of the actual organization, what are the resources inputs into the service? Are they translating into outcomes? Are they enough? In terms of the community, how is the school linking with the service? And how is that affecting the children? How is that working? So it's a systems-wide perspective. So in terms of data collection, it's going to be mixed methods. So starting with interviews with people delivering the service and the people receiving the service, who are the children and young people and their families, and lots of quantitative data that will really help us to create a bigger picture. So data from the service in terms of the patient population, their outcomes, where they're from, and a population level data to help us understand the environment around that service. And I'm also doing an online survey to understand, will be like a snapshot of what it's like when they started and at the end of the service. So the qualitative interviews, they are different because they are a realist type of interview where you're really trying to investigate. When you do this type of methods, you have what it was planned, the ideal scenario. That's how the service will work. That's how I want it to work, or that's how it was planned to work. And I want to understand how it's working in reality. So each one of those components, I will break it down and understand how is it working, why is it working the way it is it working in a specific parts? Sometimes not everything works as we planned, but it can work partially, or it might not work at all, and why, and what could be done differently. What the different people working for the service think about it, how they experience it. And is it accessible? Because it can be an amazing service, but not be really accessible for those living in North Wales, for example. How can we make that accessible and realistic for families? And are the families and staff needs being met? So thinking about the staff as well. Do they have everything they need? Again, quantitative data. So in Wales, we're really lucky to have this amazing resource called SEO. If you haven't heard about it, I highly recommend for you to have a look. So it's a data bank that covers almost the entire Welsh population, and it gives us access to data such as data from schools, GP data. So there's so much you can learn using SEO, and I'm using that, plus the questionnaire data that I mentioned. And I really want to understand things that I want to understand, that we want to look at. School attendance records, we can get that through SEO, and the administrative patient data from the service. So those are the things that I'll be looking at. And this is those are just some of the types of data we will collect. This came from the young people that were working on the protocol with me. So the age backgrounds, but also they want us to look at the family situation. Is it a single parent household? Do they have siblings? Do they have extended family around? Their pain, but not only the level of pain, but how it affects them on a daily life. School attendance, but also academic progress, because maybe they're not going to school, but they could be doing homeschooling at home. Quality of life, but also their well-being, and the use of healthcare services. Those are some of the things. If you have more recommendations of things you should look at, please pop in the chat. So there's so many things we can do with this richness of data, especially if you're using large databases. We can look at graphs to see how things changed for their child and their family over time as they join the service. We can compare differences between the same individual, but it can also compare difference between groups to see if a specific type of chronic pain condition is having more success than others, and so on. And another really interesting thing we can do is we can create simulated comparison groups to see what would happen if the service wasn't there. Would the child, the families still have the same outcomes? So promise I'm getting towards the end now. Another thing I will be doing is a cost and resources use analysis to understand how much it costs to run the service, because that will help me understand if the outcomes that we are having or seeing actually, are the cost efficiency or not, and the cost of care for each person. And you can do that by tracking the resources used, such as staff time, education, equipment, using trusted sources. Okay, so you might be thinking that's a lot of data, and just how do you make sense of it? So there's a lot that goes on in real-based evaluation, but it's basically, as I mentioned before, we have the work, the intervention as it was planned, or the service the way it was planned, and now we're testing what happened. So what happened then with what was planned? And that really helps us map the areas that are not working for specifically whom, and then really start to tailor the recommendations or solutions for the areas that are not working as they should be working. And the idea is to shape the way the service develops, because it's still very early stages of implementation where you can still change things and you can still learn and adapt a lot easier than you would if a service was implemented a long time. Apologies for the typos. This is a ChatGPT diagram, but I just wanted to show you the whole idea behind this is to use evidence to inform practice, and then use data from the practice to create more evidence to then inform practice again. And what this does is creates the learning health system, where you're always improving your service based on the data you are producing already. So the idea then with this new service in Cardiff is to continue to use research as the service evolves and continues to develop. So this is an ambition, and I do really hope to see this work. I really hope to see the continuation of this work, and hope to share the details of the evaluation in the future as well. Thank you so much for listening and for joining today. If you want to get in touch, please send me an email anytime. There's also my LinkedIn there if you want to add me. And I just wanted to share this last slide as well.
Thanks, May, and thanks for adding the last slide. There's one or two comments in the chat box. One of the questions was, are you looking at the race of children and young people? For example, research has shown that children and young people with sickle cell are less likely to receive appropriate pain treatment and management.
Thank you for that question. Yeah, definitely. I didn't mention because there's so much to pack into this, but one of our findings was exactly that the children suffer discrimination in institutions, school and hospital, being denied opioids for their management if they had a crisis. So yeah, we definitely look into that. One of the things we want to look at, and how the care for different races, but also deprivation areas. How is that working for different deprivation areas?
Thank you, May. May, can we also just highlight that Wales is a bilingual country, as in there is legislation for the Welsh language and the English language. There are also many, many children whose first languages are not English or Welsh. So has that come into your thinking, please?
Definitely, especially for certain areas where we know Welsh might be the primary form of communication. So we definitely want to look at how the service is dealing with that, and if they are taking that into account, and if children are offered, the management. Because at the moment, this is an integrated service, so that means the service is linking with the health board that is already established, and then upskilling the healthcare professionals there. So there's the benefit that the systems are already ready, the bilingual systems. Mm-hmm. But yeah, that's something I definitely want to know how that is working. Thank you for mentioning that.
Thank you. Have we any more questions that people wish to ask, please? either verbally or in the chat. Fiona is looking at the chat for us.
Thank you. I'll stop sharing so I can see everyone.
Thank you. Fiona, you have a question.
I have put my hand up to be official. I just wondered, May, you're talking about the formal evaluation that you're planning to undertake, but have you had any anecdotal feedback of the impact for the 150 children and young people that have been participating in the service so far?
Unfortunately not. I will need the ethics approval to be in touch with them, but the thing I already started, I can contact the healthcare professionals without the ethical approval. Yeah. So that's what I've been doing. I've been working with the implementation team, and I started to build a picture of the work as planned, because how the service was envisioned to work. And the next step, once I get all the approvals, will be to get in touch with the children and their families, and then with the schools. But yeah, that's a really good point, and definitely a key group that I should be getting in touch.
Yeah, they could probably guide you to inform your planned evaluation. And I'm really pleased to see that you're actually encompassing cost-benefit analysis, because the people that control the purse strings will be most interested in that.
Yes, we've learned that the hardest way. They shouldn't give the numbers, then the policymakers might not be interested. Yeah.
There's a message there, Fiona, about sharing the slides with the contact details. May.
Yeah, we will put the slides on the Association of British Paediatric Nurses website on the webinar page, past and future webinars. So you'll be able to scroll down to access the slides, and in due course we will add the recording there as well.
Okay, thank you. May, when we started the introduction to you and your work, I'm not sure that the recording started immediately. So would you mind, while we are still recording, maybe could you just show your first slide and introduce yourself again for the benefit of those who weren't with us right at the beginning? They were trying to get into the webinar. Thank you.
Sure, that's a great idea. Let me go back to the beginning, and then I'll share my slides. I also added the cartoon in the chat for everyone who would like to.
Lovely. There's a lot of really thought-provoking work, May. We're really pleased to see it.
Well, thank you. Appreciate that. Thank you for having me as well. So just to introduce myself again. So I'm May. I'm a physio by background, then turned into academic. I've been working in academia for the last 14 years or so. My work this work I presented today, it was not done alone. So I just want to acknowledge my collaborators and the people who worked with me really hard on this. So Professor Jane Noyes, who is also my mentor, she's from Bangor University, and Professor Emma France, who is from the University of Stirling. Thank you again for having me.
Thank you. One other thing, May, please, have the children who you have spoken about any handheld records and pain diaries? What type of what were they doing to record their journeys along the way?
That's a really good question. I think some of them really like journaling rather than a formal diary. They like to journal, journaling. Younger children did some cartoon. They draw. They were just had drawings. That's how we got the idea of using the cartoons. So yeah, various different ways. And others just, when we asked about that, others just didn't find it as helpful for some of them, because they said it was a reminder of the symptoms or the, and I could see, well, we didn't really formally assess that, but there's a difference in age I could kind of see with older ones, the teenage ones being more like, I've done the journaling, done all of that, and now this is kind of a reminder. But also they're all in different stages of dealing with the chronic pain. Some of them had pain for a really long time, so they kind of already found what works and what didn't work, and others were just at the very beginning, still kind of dealing with all of those changes. So yeah, I don't know I hope that answers the
yes. There are various methods for various children, aren't there? And what works, as you've really clearly said, what works for one person may not work for another, and each of the families are completely unique, aren't they, May?
Yes, and they all have their different dynamics, and
yes,
having the extended family there, it's a huge difference as well. We found that's why we're looking to if they have extended family there. Sorry, Fiona, you had your hand up. I don't know if that was a question or a...
No, May, I was trying to take my hand down.
No problem.
Sorry.
While we have still a few minutes left, I wonder if anyone else has anything to ask now, or whether any of you are doing anything similar, because I'm sure May would be very pleased to know if there is other inquiries, investigations, studies, audits going on around the UK. And nothing has come back on that query, May. So again, you've highlighted what you're going to be doing in the future. What message would you give to our colleagues if this is something that they're seeing day to day and has been troubling them?
I think if there's just one thing that could be done is to, well, two things actually I can think of. The most important one that came out of this research was to manage their expectations if you're meeting them right at the beginning of their journeys, because this seems to be the fundamental factor for them to get stuck in the cycle explained, or it will be hard for them obviously to accept if there's no possibility of a cure. But the earliest they are told that and help to manage as well, giving them the tools to help them move on from that, the quicker they can just move on to the living well with the pain. And the second thing is just amazing, the power of listening. We found that families, even if there's nothing done for the actual condition or the pain, if they just felt they're listened to, they feel better. They left the appointment feeling better. So listening, actively listening, is something that can help as well. It's a very simple things.
Yeah, and a very important point. Did you find that children and families had already repeated their story time and time again to many different professionals?
Yes, especially if they're stuck in the cycle that I explained earlier, if they're stuck on that for a long time, especially if there's no clear pathway, so they don't know where to go. Sometimes they go through a pathway which is not going to help them, but so that every time they see a different professional, they have to say again. And what that does, it breaks their trust in terms of, okay, you don't know me, or you know. So yeah, it just can get exhausting, and it just brings all those feelings of uncertainty again, isn't it? Because that's what it is, especially if they don't have a diagnosis. There's a lot of uncertainty. What could this be, especially for the parents, feeling that it could be something terribly wrong with my child without knowing what it is. So sometimes there's the pursuit for a diagnosis that can actually suppress the chronic pain management. And that's really hard to see, because then the child is suffering with the pain. So I guess all of those things are going on with that family, and it's important to be aware of that.
Thank you, May. We've got an interesting point from Samantha Samantha, do you want to speak or do you want us to read your point out?
Sorry, I couldn't find the mic. Yeah, I was just wondering, with the active listening for the children, I'm assuming an important part of that was that they were being heard and they were being trusted, that they were telling the truth about their pain?
Yeah, I think that was definitely one of the components, especially as sometimes there's all those things that we found that, oh, you're just saying that, just keep school, especially if it's at the very beginning, not saying that was quite common, but it was quite at the earlier stages of their journey. So that helps with the child to know, okay, you know, that's actually happening, or it's not all in my head, because that's one of the things I heard a lot, children saying, like, it's all in my head. But also the active listening is not so much about their symptoms, but the impact on their whole lives. That was very important to them. So the impact on their lives, the disruption of their routines, not feeling normal anymore. So things actually went beyond the symptoms, which are the things we'll be looking for if you're trying to give them a diagnosis or think about a management strategy. So I guess going a little bit beyond the clinical evaluation, if possible. I know time is a problem most of the time. Yeah.
Thank you.
Thank you.
I think we could just take Julia's last point because we are coming to the end. Julia, do you want to ask May about the strategies, please?
Yeah, sure, May. I was just wondering, 'cause obviously families understanding the kind of concept of the biopsychosocial aspect of pain, you know, what strategies would you suggest to kind of move them from thinking about it as that physical, looking for a cure, to sort of moving them onto plan B and then accepting those, you know, other treatments?
Yeah, it's a tricky one. I'm afraid it's not a clear answer for this, but I can tell you, based on the evidence, what we found and the experience, sometimes communicating it depends on the approach. If you're asking them, have you considered those other things that can help you, the psychosocial strategies, explaining why, and they want to know more about their condition and the pain. So explaining the pain is got all of those different aspects, because one thing that we found is they can feel all the impacts on their lives. The impacts are biopsychosocial. So there's that, they're all biopsychosocial impacts. So within that, you can draw comparisons. Okay, you're having this impact on your life, which is psychosocial. How about this strategy? And then being clear that you're not offering this because you think the pain is on their head, or you're not. It's trying to get away from that stigma, which is quite difficult, isn't it? Just communicating. That's the reason. I think they want to know what is the reason I'm being offered this. Because if it's just a referral, or I think you need to talk with this therapist, they might feel blamed. But if you explain, it's because what we see normally is the pain is biopsychosocial. So to treat the pain, we need to think about all those different components of pain, which includes the biomedical, the psychological, and the social. So that's why. So I guess it's just clearly communicating. I don't know if that helps, but
Thank you, mate. No, that's really good. It's just one of the questions that you often get asked when you're talking about chronic pain is, how do you, approach that subject? And obviously, a lot of people's experiences are, they have medications and then the next thing they're being offered, therapy or, talking about their sleep and physical exercise and but not really understanding the why, as you say, which is great. Thank you.
Thank you very much, Julia, Samantha, who've spoken. We're getting a round of applause for you, May. It's been a fascinating webinar, and I'm sure we could go on talking for much longer, but you've given your contact details, and if people do want to get in touch, they are very welcome to do so. We thank you so much, May, for joining us this afternoon. Before everybody goes off the call, I wonder if Fiona has any last messages around this webinar or future webinars.
The details for future Association of British Paediatric Nurses webinars can be found on the website. And if you're following me on LinkedIn, you will hear about them because I post there frequently. The next webinar, I believe, is on the 28th of October. And it's around preparing, educating and developing the children's nursing workforce for the future.
Thank you very much.